Okay, now we're going to talk a little bit about some of the metabolic changes of pregnancy that make gestational diabetes happen sometimes. And then we're going to talk about some of the risk and complications of diabetes. So in the first trimester, estrogen and progesterone levels rise, and that actually causes increased insulin production. That means that we use more of the glucose we take in. It can actually lead to some hypoglycemia at times in the first trimester. We decrease glycogen stores because we're using more of that glucose as it comes in, and we're using that glycogen when we don't have enough intake. The liver breaks down that glycogen. So we're storing less glycogen, releasing more of the glycogen, using more of the glucose we take in. The mother's insulin, women who have type 1 diabetes are actually prone to hypoglycemia during the first trimester. And people who are not diabetic may have mild hypoglycemia during the first trimester, and it can actually make that nausea, vomiting worse. In the second and third trimesters, the tissues become a little bit more resistant to insulin. And that means more of the glucose stays in the bloodstream to get to the developing fetus. So we store less glycogen, the liver releases more glucose. All of that's to ensure a continuous supply of glucose for the fetus. But if we have some insulin resistance already, we get more insulin resistance and more glycogen breakdown, we can end up with elevated blood sugars. Women who have diabetes usually have an increased insulin requirement through the second and third trimesters. Now, glucose crosses the placenta, so it gets to the fetus, but insulin does not. And so the fetus actually makes its own insulin. The fetus has a pancreas, begins to produce insulin. And so all of that extra glucose, when the glucose is elevated, all that extra glucose goes to the fetus. The fetus has insulin and knows what to do with it. At birth, when the placenta is expelled, the hormone levels drop drastically. The maternal tissues become sensitive to insulin again. And so for postpartum, about the first week, insulin requirements are low because we've been insulin resistant. So we've had increased insulin doses, and now we're not insulin resistant anymore. We're sensitive to insulin again. And so if someone is already taking insulin, their insulin requirements are going to decrease in that postpartum period. Lactation also uses maternal glucose, so insulin requirements stay low through lactation. Now, what are some of the risks? If someone has diabetes and they are pregnant, someone has pre-existing diabetes, if they have poor glucose control, they're at greater risk for miscarriage. If they don't have good glucose control, they can have a really large baby, and we're going to talk about why in a minute, but that can lead to either having a C-section or operative delivery, which has its own risk. Those bigger babies of the mom with diabetes are more prone to shoulder dystocia, which is a birth complication when the head delivers and the shoulders get stuck. Someone with diabetes is at greater risk for preeclampsia, greater risk for preterm birth, greater risk for maternal mortality, greater risk to have too much amniotic fluid, that's polyhydramnios, greater risk for infection, and infections can get more serious. Pregnancy increases the risk of DKA for a patient who's diabetic because blood sugar can be higher, but also DKA occurs at lower blood sugar levels. So pregnancy really changes diabetes management a little bit, and the patient has to really be on top of what's going on with their body. If they have preterm labor, terbutaline and corticosteroids, which are two things that are used in preterm labor management, actually increase blood sugar as well. Hypoglycemia is also more common. Some risk to the fetus: intrauterine fetal demise due to that vascular damage, congenital malformations. These are more common with really poor glucose control. Hyperinsulinism means the baby makes insulin to cover all that extra glucose they're getting, which means they keep getting bigger and bigger because all the glucose comes in, they make all the insulin to cover it. They just keep packing on weight so they can get really big, which can lead to birth injuries. And when the baby's born, they've been getting all this extra glucose, they're making extra insulin to cover it, umbilical cord is cut, and now the glucose supply is cut off abruptly. So they're still making insulin to cover all this extra glucose they were getting from mom. Now we end up with neonatal hypoglycemia. So those are some of the potential complications of diabetes in pregnancy. We're going to talk next about managing diabetes.